We will have Dr. Lohith sir is with us, so he will be talking about resident Sangha. Bhavik sir will have an introduction of Lohith.
So again, Lohith is a young, dynamic VR surgeon. He is from AIMS, and now he is a localite here, and he practices in Vishaka Institute. Please go over to you.
Good morning, everyone. Actually, this was the most difficult presentation I have ever made, and it is exactly opposite to the previous presentation. I am talking about how the resident should be. Resident, what the definition, what means is who lives in hospital, where he or she works under training program. He develop and learn the skills necessary for their chosen specialties, provide direct patient care under the supervision. What are the responsibilities? Professionalism we have to maintain, and the punctuality. Why should we be punctual? If we become punctual and the staff will be punctual and the patient, the one who is in a negative vibe, waiting for the positive thing, and the discipline. How the professional discipline you are maintaining, how we are communicating, the communication skills also matters. Cultural awareness. What we have to do is in the ward or OPD, we have to maintain the same culture maintenance in all over the integrity. We have to maintain good communication with the juniors and seniors also. We have to stay calm and never lose the cool. Ensure the patients that the finalists patients feel safe and secure. Supervision. There we can have the direct supervision and indirect supervision. Direct supervision, the senior trainee presents at the patient care. Along with you, the bystander will be the senior trainee, senior resident or senior consultant. Indirect means indirect with the direct supervision with a phone call immediate within the hospital. Indirect supervision with telephone or electronic medias. Oversight, review of work and intervening the feedback. The first whatever the ophthalmology resident joins the first year, thinks of only dilating the patient and giving periorbital blocks. But what else we require is apart from that, it is a training program. So whatever work we do from the day one process, it actually impacts in the consultant career. The case sheets, we have to fill the case sheets during the first year. It's a medical legal document. It will be helpful in the further when we face any medical cases. And research assistant also. Actually done the work we done in the ward, OPD or in OTA, assisting the case for the seniors also. We can be useful for, and your name will be the along with the work that was done in the hospital. Sampling. We do every sampling every resident feels that okay, we are done with only samplings here, we are not attending, we are giving direct access to the patient. Some people the actually sampling after the COVID intervention, what we are exposed to the COVID duties, and what we learned is after the COVID we are more exposed to the systemic evaluation, especially which was very important in treating systemic conditions like uveitis. And OR list. Prioritize which surgery should be picked first, how many hours it will take the surgery, which surgery. If we put the VR surgery first, we can relax, the actual resident can relax for at least 30 minutes so that he can put cataract surgeries later. So the prioritization also resident will acquire during this preparation of the so-called case sheets or sampling, a routine blood work or OT list. What do in the second year? When we move to the second year, the first year previous slide should be complete. Now we should be more concentrated on the thesis work or project work and the surgical work. Okay, these two are very important because it is carried away to it will be forever, remaining will be forever in the resident life. So case presentations, journals, case presentations, symposium, everything we have to be acclimatized to. And peripheral work. Apart from the ophthalmology, then we have to know what the patient holistic. Nowadays we treat the patient with a holistic approach. We take the help of dietitian, endocrinologist, pulmonologist, rheumatologist for treating diseases. So we should know what are the peripheral branches, how to accessibility. And community work when we go to camps, when they recruit cases for our learning, it tells about the communication, when we are talking to the patient, it is only to one-on-one approach. When we go for community work, we can actually treat the masses. we are handling the mass of the patients. And the train the juniors. Why should we train the juniors? Apart from the maintaining the harmony also, one we can't, and when we go to second year, we should not do the first year things again, so that we have to plan the third year things. So if you train the juniors, then we can have a lesser burden, so-called lesser burden, and we can move on to the other project. As we discussed, thesis and project work and surgical skill we have to acquire in the second year only, so that we think that usually in the third year we will excel ourselves. Suppose if you were given pterygium surgery or collagen surgery, no, I will operate in third year. No. Whenever it is given, it's do that. We just move on to the other things, because there are things we have to concentrate in further. When you move on to third year, the completion of previous 2 slides, and we have to go for expertise our skills. How to handle the patient. If a patient comes in the OPD, we have to diagnose there itself. We have to have a gross idea. And in the surgery also, when we do the surgery, we have to keep in mind how the patient behaves in the first post-op POD or fourth POD. You should expect knowledge acquisition. It is the third year is the only time where we actually study. Otherwise, after when we go to fellowship, when you become consultant, we won't read that sit and study in that. We can't dedicate our time to the books. We will revise the brush our knowledge only. So whatever the knowledge acquisition we have to do in the third year only. Plan the future endeavors. What are the super specialization you want to do? You want to take a break. So before plan, you have to make some plans in the third year itself. Personality, you have to take the attitude. You have to build up our attitude in the third year only. Like personal life, if your family, friends. So we have to plan everything in third year, so that you have just move on. You should not waste time, because now we are not, we are moving from SICS to FACO. We have moved from the SICS to FACO. Next will be the super specialization. Of course, we are in refractive, retina. So we have to plan again in third year only. We have to prepare either for the interviews or the examinations. And specialization, we have to clear idea what specialty you have to take. These 3 residence area only, when we don't think about these branches are a lot of and learn more and more money. These are more user branches. People talk more about the branches. No, this is a residency time only. We will have the much exposure regarding the ethical work. Surgeon. It was taken from the American Academy of Ophthalmology, the making of a great surgeon. The recent volume makes a surgeon sharp, and deliberate practice over the years makes him skilled. Total volume over the career makes a surgeon wise. So sharp, skilled, and wise surgeon, it completes a surgeon. And why do we need a advance in ophthalmology? We should know the advance ophthalmology. We should compete with others. It's not like okay, we will learn, we will expose. We have to talk. We need a platform like AIOC, so that we can talk. Journals, you have to go through the journals, what's going on in every different specialties, and scientific sessions. Attend the scientific session, get exposed more, know the cutting edge technology, what are the recent advantages, how the visual outcome and functional recovery, how far I can give it more than this. And artificial intelligence, it is a newer thing which was an impact on our day-to-day life. Biostatics analysis, we should, apart from taking the help of the statistician, we should know basic knowledge of the statistics of going on also. Research work, potential case, every OPD case has a potential to publish. That's what we have to give a time for it. And teamwork, include the juniors, seniors, and take the help of staff, OT assistant, optometrists, so that if we involve actively, they get inspired from our work. Acknowledgement, whoever participants, the one who participate in as a teamwork, better acknowledge everyone. Then financial and technical issues, when we're dealing with artificial intelligence, there will be the financial issues also. Then have to be also take care. And accessibility and availability of the research work. Teacher, what is a passive learning? What we learn from the teacher is a passive learning. It might be passive learning. Now we are moving to resident approach. If we give a topic beforehand, 2 of the residents will learn and will discuss with the other residents, and this is moderated by the supervisor senior ophthalmologist. It is published in the IGO also, the residence to resident teaching. Revision of multiple topics happen at the same time, and we can discuss the planning of discussions also. what else we are completed, how far we are up to, and what can we learn in the future. And a good listener. The resident should be a good listener to the patient and the colleagues and the family also, and especially the author of the guide or examiner in the Viva also, or in Viva also. What the examiner says, he is correct. We have to be there. And the professional, we have to take care of ethics, beneficent, to act in the best interest of the patient, do no harm to the patient, autonomy, the patient's right to refuse and choose content. So whenever in the first year only, you should, when you're taking the consent, you have a gross idea what can happen in the future. Justice, who gets the treatment on the merit of illness. Dignity, patient and doctor both have a right to dignity. Truthful and honest, the patient deserve to know whole truth and illness of the treatment. Now we are discussing the live surgeries. Now we are taking the video consents. So patient should be aware of whatever doing at what presence, and how far we are advising also. Sometimes we will tell the consent to the attendant. No, patient should also know about, in current generation, patient should also know the condition of the disease. Reasoning why it is happening, because it will make you to correct immediate action, to correct the mistakes, and easy understanding and long-term memory. If you know, when you learn from the previous mistakes, you need not to revise everything, it go for a subconscious memory. Observation, it's a good tool of learning. 90% of learning we go from the observation only. We see the cataract videos, we see the cataract of surgeries from our professors. We do 90% of our learning is from observation, and observation thing we should put in the practice, and accepting and strength and limitations. Whatever strengths, okay, we are not able to make tunnel, okay, practice it. And whatever tunnel is just not, iris is pulling out, you can how to manage it. So you should accept, okay, I am not able to do that procedure, so I need a immediate correction, senior help, or take the help, go to the literature, go see the videos. So we should accept our strength and limitations also. Focus, start with the basics. When we give the advice on a resident in the first year, start with anatomy and physiology. When we open the book anatomy and physiology, he will read or she will read, dedicate one day for reading the first page only. So better to go with retrospective study. I mean, if you go with the retina, if you note what are the layers of the retina, when you go to the pathology, okay, it is a cotton wool spot, where is it, why it is happening, and go retrospectively to the anatomy and physiology rather than prospective. So it will save the time and also have a gross idea. Change the focus. When you do the surgery, when you are maintaining the AC chamber, entering the AC chamber, if you have a difficulty in the MVR entry or side port entry, if you are moving it anterior and posterior, so we will try to make it corrected. Then change the focus. You make a goal that, okay, I will make a tunnel best, I will prevent corneal edema. We can escape that entry difficult thing. Apply in all aspects. Whatever focus is, apply in all aspects. OPD aspect, OT aspect, and the academic also. Don't get carried away by the advices or previous delusions of what we learned from others. You should have some perspective. Evaluation, identify the cause, whatever the mistake you have done, and assess it, and immediate correction. It will save some time, and we can develop in the future, so that it won't be repeated again. Thank you. The take home message is work hard and party hard. Thank you.
Thank you so much. So I would like to ask you one single question. So when you're starting your practical journey, the practical surgical journey, how important is wet lab training according to you?
Sir, wet lab training you can do without, due to the wet lab only, in the training also. For example, for capsulotomy, if you directly go to the patient and do the capsulotomy or capsulotomy, it's very difficult. And wet lab also, when we suppose we train in the go type, the tissue difference also, will be more elastic in the go type. And when we in the humans, when we train in the humans, it's not that much. So wet lab.
May not be exactly like in a human eye.
Mm.
But don't you think if you practice a lot more tunnels in a
Yes, sir.
God's eye
Yes,
and we start that on a human eye,
Human.
it becomes a lot more easier,
Yes,
right?
yes.
But nowadays, I have seen that the students directly want to try it out in the human eye.
No,
They
no, no,
want
no. I
directly
don't.
want to experiment it. They
Yes,
just
yes.
want the numbers to increase.
Yes, sir. That's
Right.
why I mentioned surgeon. It's not the number.
So, eye is the most precious organ in a human body, right? So, you should not go and experiment somebody's most precious organ. So,
Yes.
first you have to be thorough with this step, then only you go and experiment. Whoever be in the surgical bed, consider it as one of your relative or your parents and then do the surgery. This is something which my professor told me when I was starting my first case.
Yes, I think it
But
as
that still holds true. Try to consider it like that.
yes. Think it as a family member. When you treat the as family member, you won't make any mistakes also.
Yes. Thank you, Lohith, and thank you, Rakhi, for the wonderful comments.